Okay, so welcome everyone to this ARMA webinar, which is about a new way of delivering pain services. I think it's going to be a really interesting webinar, looking at a very practical example of where this has been done in the past. But I'm just going to start with a couple of polls to just see who we have on the line. So if everyone except the phone call listeners should now see a poll on their screen, and if you can just click your answer to this, then we can see who we've got on the line. So it mostly seems to be commissioners at the moment, physiotherapists, we've got some patients, we've got some pain specialists, researchers. So the only thing we don't have at the moment is GPs. So that's a really nice range of participants. So I'm just going to end the polling and show you the results. So everybody should there be able to see, as is normal with an ARMA webinar, our top two categories are commissioners and physiotherapists, but we've got a nice mix of other people on the line. And I think we still have people joining a bit late. So and then the other thing I'm going to do is just a quick poll about how you would rate pain services in your area. So just take a look at these and indicate whether you think pain services in your area are up to scratch and where they sit. So we've got lots of votes coming in, and we've got quite a range here. Some people who feel their services are excellent, and we've got a few who feel their services are terrible, and mostly somewhere in the middle. So I'm hoping that everybody who hasn't said excellent will find some useful things in this webinar. And we'll just stop the polling there because most people have voted, and share the results. So there we go. There's a few saying excellent and a few saying terrible, but most is either needs some improvement or okay but could be better. So hopefully this webinar will help you to know the best way to do that. So I'm now going to hand over to our two presenters who are involved in a pain service that I think you were both involved in setting this up, weren't you? So we've got Dr. Anthony Chan, who is a consultant rheumatologist, and Dr. Rupert Woolley, who is a GP. Both of whom have experience of how this service works. Over to you.
Thank you very much. Thank you for the invitation for both Dr. Woolley and myself to come and share with you some of our experience in setting up their integrated pain service. So we'll start with the presentation, and then we'll talk through with you how we went about doing this. So we'll share with you today how we went about setting up a very innovative and integrated care pathway in terms of managing patients with pain. So the issue is that pain, and particularly back pain, is a big problem, as we know, for the UK health economy. And this is now shown in a very recent paper only published last month in The Lancet, showing that in terms of days lost from disability and in terms of mobility, back pain tops it all. And so there is a huge need for us to be thinking in terms of providing services locally of how we manage pain, not just back pain, but also generalized pain in terms of the services that we provide, because doing the same clearly, as shown as in this paper, a major problem in terms of mobility, days lost at work, and also costing the financial, the NHS. So before we start any further, I wanted to ask all of you to write on the back of a piece of paper, how much did you think 20 patients who circulated the system because of pain and attended numerous clinics in the hospital, numerous therapies over a 5-year period, how much did it cost the health system here? And if you can write that down, Dr. Woolley will reveal to you the answer at the end of the presentation. So how much did 20 patients cost circling the system over 5 years in terms of managing the pain and attending different specialties? And we'll reveal to you the answer at the end of the webinar. But it all comes down to the patient. So when we when I see patients in the clinic, I kind of think of how does this patient fit in terms of where they would go. And so here is a case of a patient who attended my clinic and had spent about 15 months circulating the system, as in attending various different clinics in terms of trying to manage the pain. The patient was seen by the GP and then referred to an MSK service and ended up seeing numerous different people at different time points. Physiotherapists, osteopaths, acupuncturists, massage therapists, orthopedic surgeons, neurology, pain clinic, rheumatology, lower limb pain, upper limb pain, spinal, orthopedic. And at various different points, everybody was trying to do their bit. And the patient was then trying to find an answer to a total solution to their pain. So at one stage, it could have been a shoulder that was injected, a back that was looked at, a foot that was treated, or swelling in a joint that was treated. And the patient went on through this sort of cycle. At various different times, she was in extreme pain and had gone from one person to the other. And at various different points, had different diagnostics as well. And this comes to show that this is the size of the problem that we are facing. And this is at no fault of the patient or any of the people who've seen them. Everybody is trying to do their bit to help with the pathway. But what is really important and very clear to us is that this shouldn't be allowed to kind of carry on as it is. What we need to do is to line all of these different teams together and to put the patient in the center of our care so that we can just do a bit better in terms of having a more joined up and integrated service. So what we decided back in the 2014 and 2015 was to come together with all the community.
I think you've frozen. Sorry, we've been having a bit of Wi-Fi problem at Tony's end this morning. Hopefully that will pass. Yeah, no, he's now dropped out completely, I'm afraid. Hopefully we will be able to...
Thank you. Okay, so we decided back then to come together to form a group to look at how we can manage chronic pain better. So this was a group of physicians and clinicians and commissioners and GPs coming together in the same room from both the community and acute trusts to kind of think about this very patient that I just described to you. If we put the patient first and kind of think of how that patient journey would be, what would be the ideal if we were to redesign the service. And so this is where we met. This is a squash court in the acute trust in my hospital. It was where we all met, and obviously it's now used for other reasons. It's a training room. But when I walk in here, and I often look at this place, and I think this is where the ideas were first created. And sometimes there is a lot of power in just trying to get the right people into the right room and trying to kind of solve the problem together as a system or as a group of skilled therapists and physicians to try to deal with the problem. There's a lot of mileage in trying to do that, and this is how we came up with this idea. So what we decided then, it would be we had all these right people in the room, and what we needed to do was try to streamline the process and try to bring together all the clinicians and therapists to think of how we can see the patient rapidly, to have a more MDT type approach where there was early intervention for management of the patients, and truly to be an integrated service where there is no sort of difference between acute trust and the community trust or between primary and secondary care. To have the right place, to see the patient in the right place at the right time, and to kind of signpost early so that we can try to deal with the pain and not to allow it to become chronic. So this is a traditional pathway. We have been working with this pathway for the last 70 years in the history of the NHS. If a patient goes and sees a GP, the GP tries to manage them with their pain. If that doesn't work or if you can't manage them, then they would send a letter to secondary care. Secondary care would see the patient and send the letter back to the GP, and that will be one episode. Now, if that is not dealt with, then this sort of linear fashion referral continues to happen. And we felt that this is what was happening. So instead of doing that, we kind of moved towards a more circular, modular fashion, where we put the patient in the center of our care, and if the GP, the acute trust, our community providers, and also social services are important as well, to kind of think of how does this patient then match the requirements of what does the patient actually need in the center of our care, and try to be in a more integrated fashion. And we felt this would then reduce the time that patients would have to spend with numerous different departments or different therapies. So this is our local area. We serve a population of over 500,000 patients. And obviously our core center is in Reading, but we go out as far to the east and to the west as shown in this map here. And we were trying to say how can we deliver the care, not just in the acute center, but also out in the peripheries, that all the patients will have equal access to management of chronic pain. So I'm going to pass you now to my colleague, Dr. Willie, who's going to explain to you the next part of the presentation.
Hi, thanks very much, and apologies in advance. My voice is slightly giving up, so I'll do my best to keep going. So you've heard about how things were in the past, the ideals, what we're aiming for, and that rather traditional sort of linear pathway. And so this is the sort of new model which we come up with now, in that the GP now has access to online resources to help them improve their pain management of the patients who come to see them. And we have an online system called DXS, which is a resource for guidance and also referral pro formas and things relevant to our local area. And so that's a resource GPs can use to access for guidance and then for onward referral. Simple one-page referral with the sort of key points of what's happened so far in that patient's history. The patient then goes into the IPass system, the Integrated Pain and Spinal Service, where they are triaged, and I'll explain in a second. Service and IPass.
So you've frozen again. I don't know if you're able to hear me.
Can you hear me now?
Yes, that's fine.
So put in place changes so the GP has to online resources to help better manage
No, I'm afraid. Oh.
So there's the GP resources, I think most of you've heard about now. Then the community-based integrated pain and spinal service, where the majority of patients would be managed, and I'll come on to that in a second. And then, whereas previously everyone would have been referred to a secondary care pain clinic or surgical specialty, now only around 30% go on to that level. And we're looking to complete the pathway within about 12 weeks, whereas previously the waiting time just to be seen for a first outpatient was several months longer than that. So two main pathways within the IPass service. There's the spinal pathway, which is more a traditional medical model of approach. There's a paper-based triage and then an assessment with a physiotherapist. They have access to investigations. They can directly book MRI scans if that's appropriate. And then we have mentoring with a consultant. Those physios review the patients and the scans with the consultant, and then patients can be directly booked for procedures or referred onto a specialty as needed. But majority of patients, we hope, will not need that and will go into the back rehabilitation program or community physiotherapy or other services in the pain arm, which can help their kind of pain. So the pain arm is much more the sort of an MDT biopsychosocial approach, you get a face-to-face triage, face-to-face assessment. That might be the physio, but also as many as possible are done combined with physio and psychologist, and a few are just seen by the psychologist on the first appointment. And from there, you can see we've got a whole range of options available to those patients. We have a community pain consultant who mentors the physios, but also sees patients either one-to-one or part of an MDT. There's psychology sessions. There is the pain management programs, a level 1, level 2, and a separate fibromyalgia program, as well as the back rehab classes. And these are all tailored programs, both psychology, physiotherapy, goal setting, sort of helping patients to set activity targets in their own lives and set their own goals as to what they hope to achieve going forward. And this is where the majority of the patients are monitored, but the pathway doesn't stop there. You can then be referred on to specialties if that's necessary. Some patients go back to the GP after that, but may then need further input down the line. Excuse me. So the pathway doesn't end. It is, as we said, a pathway wrapped around the patient to suit their needs and to change as their needs change going forward. This is just a little bit more about some of the groups we have. The pain management programs, fibromyalgia, and then explain pain, which is kind of more about, we find if patients understand pain, understand the processes going on, it really helps them to manage it and to manage their expectations as well. And more active groups such as Back to Fitness and Bodyworks. So in terms of our outcomes that we've been running, we do a lot of outcome measures, and as you can see on all those groups, into patient self-efficacy, so that's helping them to manage and their confidence in managing their pain themselves. Obviously outcomes are improved, their functional abilities have gone up, and what we call the flourishing scale, again, patients in terms of quality of life, all those measures have improved between assessment and discharge. And then this is the sort of, for the commissioners out there, the sort of the financial slide. If you look, the green line is the cost of these pain patients to the system before IPass came into existence. And then the purple line is the first year. You can see in the first 3 months, the costs went up a little bit as there were set up costs, but then from after that, there's been significant savings and then further savings going on into the next year. We anticipated we were going to save around about £110,000 a year. Actually, at the end of 2 years, we're on 344,000 there. So the question Anthony asked you at the beginning was, our 20 highest cost patients to our system, patients who've been in the pain clinic, but also been in other parts, how much did they cost our system over 5 years? Those patients had cost us £1 million between them, just 20 patients. And that shows really that is not a viable way to deliver care, and it clearly isn't care that's working for the patient either. So by really not necessarily creating whole new clinics, but moving the clinics together, bringing everyone together in a coordinated, integrated approach, we can improve patient care, patient satisfaction, and make significant savings to the system as well at the same time. So we've been running now for just over 3 years. We brought the IPass service in just prior to the release of the latest NICE back pain guidance. And actually, they did look at the IPass clinic when formulating those guidelines. And if you look at the guidance, it more or less matches what we had already started doing in the IPass service. We've spoken at regional and national meetings, and we've now published a toolkit of how we've gone about producing this service, which is available for other systems to use if they want to look at implementing a similar system. And the other thing is, we'll talk about this later, we're now an integrated care system in the Berkshire West, which is about bringing all the stakeholders, the acute trust, community trust, GPs, the CCG, together to work as one single system, not as competitors. but really IPass was the first, the forerunner of that. We were doing that a year or so before the rest of the system moved in that direction. So we're very proud of that collaborative working. Obviously, there are challenges when you're setting up a new service like this. There was pressure to get the service up and running in time, which it puts pressure on recruitment and logistics. We showed you a map earlier of the region we serve, which is quite a spread out area. So we're very keen to be offering this out of more than one centre. We run it out of 3 centres across the area, which brings it into the community. It demedicalises it. Some of the clinics are run in church halls and various different places, so it demedicalises it. But that does obviously produce challenges in terms of scheduling, getting the right people at the right place, and making sure there's enough space. As the service goes on, it has been very successful. It's very popular with GPs and with patients, and so increasing demand of the service, and so we have to kind of adjust capacity to reflect that. At every stage, we've had patient input. Right from the beginning, we had patients in the room when those first meetings back in the squash courts, and that's been really important in shaping the service. And we'd just like now to show you a video we made with some patient perspectives on their experience of the service.
Now, this may be challenging the Wi-Fi too far, but we'll give it a go. And if not, we'll send you all a link to it so you can watch it online afterwards.
Can you see this?
No, we've got the sound. We've not got the visuals yet.
So we need to go new share and do it there.
Oh yes, it might be because you're not sharing the visuals yet. Yep.
The most amazing thing about my first contact with IPass was the care and time shown and given to me. It really was a revelation, because after 10 years or more of having had this condition, it was the first time I felt I'd met any health professionals who understood the nature of the condition and what it was really all about. You cease to be a national health number, but become a person who they clearly care for and want the best for you. So patients are coming back to their team primary care and they really got listened to, and they've been able to explain their need and have the time to fully understand of what the issues are and what the solutions might be. I think it's practical terms, taking to a community on every repeating bits of pain that had solved. And they said, I found other ways I can manage my pain now. One of the great things about IPass I found is that it's taking place in the community and outside hospital setting. And the ability to go to somewhere fairly local that's in your community, away from a hospital, is definitely attractive to some patients without a doubt. You work in a small group and have a combination of health professionals leading it, but it's very interactive and you have many opportunities to discuss with other participants, tips and ideas as well as from the professionals.
And for me, come to the sessions and hear other people, what they're going through.
Got a message coming in saying people can't hear the audio, and I think we just don't have enough bandwidth for showing video.
I'm very impressed with how quickly that connected.
So perhaps if we stop that, and as I say, we will make sure that everybody gets a link to that so that you can watch it afterwards.
Okay. Okay, thank you. So that's the link. And so we were very proud because the way we had set up IPass was prior to the actual formation of the integrated care system. And today we are in this Berkshire West integrated care system, where a lot of these new work that we're doing is kind of modeled on the IPass, where bringing together all our GPs and our community providers and the acute trust, social care, even public health together to kind of think about how we think about the patient and their patient journey and how that pathway can be made better. So we're very proud to also be a winner of the British Society for Rheumatology Best Practice Award, and we're also finalists for the HSJ Award. So we feel that this is something that can be replicated across the country. We have a toolkit. It's available on the BSR
And I think that's cut out again.
website for you to take it back to your
Back.
Okay, take it back to you. Okay.
Okay, yes, you're back. But I think we missed the last, what you were saying about the last slide.
It's probably less important.
We'll just go back to so we were obviously very proud to be awarded the British Society for Rheumatology Best Practice Award, and also a finalist for the HSJ Award. So we have a BSR Toolkit on the BSR website, which centers across the country can use and hopefully replicate in their own areas as well.
Okay, so we should be able to send you as well a link to that toolkit. And it looks as though we have lost our presenters again for a moment. And we've got some questions coming in. So thank you very much for that. And that toolkit sounds great if anybody is wanting to do something similar. So the first question I've got here, a kind of fairly factual one, which is what percentage of patients need the secondary care pain services?
It's about, I think we work on about 30% onward referral from the IPass outward to secondary care.
Okay, thank you. And then the second question we've got here is what lessons can be taken forward and applied in other pathways across the integrated care system, particularly around patient and public involvement?
So within the integrated care system, we have several projects going. We're having looked at pain, we're now looking at wider MSK provision and whether a similar sort of IPass model can be adapted to other sort of MSK areas. There are also kind of changes around urgent care and other sort of inpatient pathways like sort of cardiology and things we're working on, and taking that more integrated approach. You mentioned about patient path. I mean, that's been quite a key part of how we developed IPass, and certainly patients are involved at every level of the ICS as well in terms of engagement when we're developing these services.
Okay, and then is there a plan to integrate the MSK and the pain services?
I suspect if we kind of change the way MSK is provided and go to this more sort of community-based approach, but not just community-based triage of MSK, but actual treatment and access to diagnostics, then yes, IPass may well become one option within that pathway, but we haven't really got that far down the line yet in terms of IPass is a success. We don't really want to change it. You know, if it just becomes an extra option for MSK patients, but it's not going to lose any of its characteristics if we do integrate a little bit more with wider MSK.
Okay, thank you. And then a question here, can you please describe how re-referrals are managed within the pathway?
Can I answer that?
Yeah, I mean, so if you're saying that somebody's completed the pathway and gone back into the community self-management, but they're struggling with their pain, a GP can re-refer into IPass, and then we sort of pick up where we left off rather than starting from the start. We've got all that records, information of what went on, so we don't go repeating scans and things if that's not needed. That's the beauty of the system. We've got all the information there, so we can carry on from where we left off and offer other options within the pathway, rather than starting in or more scans and more investigations.
And the other thing to say is that we get also direct referrals from the IPass. So if GPs have referred their patients to the IPass and it's felt that they needed a more specialist type opinion, and that's only we're talking about a third of those patients, they can not only go to specialist pain services, but they can also attend rheumatology, neurology, or orthopedics without the need to go back to their GP for another referral.
Okay, so that's all of the questions that we've had so far. If anybody has any further questions, please do pop them into the question box now, while we have the presenters on the line ready to take them. And we hope you found the webinar really useful. One thing that might also be good is while we've got another question coming in, so we'll come to that in a second, but while we're dealing with the questions, if anybody has a thing that they're planning to do as a result of hearing this webinar, please do pop that into the chat box so that we can share actions that people might be taking. So yes, more questions coming in now. So the first one is, how much have you seen others adopting this model elsewhere and learning from your experience?
So we have spoken to various different teams across the country since we've started up IPass. We have shared our BSR Toolkit with our various different teams, and we know that certainly quite a few areas are already starting to make a lot of progress in using this similar model.
Now, I think that's a really interesting question, because there's a lot of issues around how do we take an example of good practice and spread it in the NHS, and that seems remarkably difficult to do. So it's really good to hear that you have been able to do that, and that's part of the reason why ARMA does these webinars, is to try and give a bit of a profile to examples of good practice. So that's brilliant to hear that you've actually managed to get some spread. So the next question is, your psychologist employed by IPass, or do you use PWS/IAPT?
They're directly employed within the IPass service. Yeah, they're part of the team. That's the great thing. They all work together in the same building, and with the same goals.
Okay, brilliant, thank you. And then here's an interesting one. How did you ensure buy-in from your GPs and compliance with the pathway?
Yeah, always a difficult one there. So we had a big launch event at a GP education afternoon. We took over the whole afternoon to discuss the pathway, and then we also did some educational work around pain management, and then followed up with lots of kind of online promotion of the service in the run-up to the go-live date. The way it's set up on the referral system is that you can't directly now access the pain team at the Royal Berks. You have to go via the IPass service, which is on e-referrals. There are other providers in and around the system who provide some sort of pain services which are still available. So to some extent, there's a little bit of mandating that this is the pathway we use locally. A lot of promotion.
And I'm afraid you've frozen again. So hopefully they will be back very soon.
With a lot of promotional work, to GPs initially, explaining the pathways, explaining the process, making sure the IT was in place, that things actually worked. There's nothing that annoys GPs more than referral processes that don't work. And then on e-referrals, it was set up that if you needed access to a paying consultant, you had to go through the IPass service locally. And that got initial use, and then word of mouth that actually we were getting positive feedback from patients and GPs. That really established the buy-in going forward. So it really isn't an issue now. GPs see this as the default service locally.
Okay, that's brilliant. So it sort of keep plugging away until it embeds itself. So I've got a question here. Was there any duplication of roles in IPass and the pain service, e.g. psychology, physio? And if so, how was that managed?
I think it was more patients' job roles slightly changed, and they sort of moved a little bit around the system. But so we were setting up. We got a lot of the people already in place. It was just making sure that a little bit of and now some flow. There's programs having 3 the pain clinic in Royal Berk, so so they work well together.
Yeah. So carry on. Where were we? Well, we had a question come in about sending out the slide pack. Are you happy for us to share the slide pack afterwards?
So we got 2 questions here. Yeah.
So can you hear us? We can hear you.
Yes, we can hear you. Yes.
Yeah, we can hear you.
So are you happy to share the slide pack afterwards?
Yes.
Yeah.
Yes, we're happy for that to be shared.
Okay. And then the other question is, what percentage of patients who were previously seen in SC pain services were managed in the new service instead?
So only a third of these patients who used to be in the secondary care service remain in the secondary care. The majority of them are managed earlier in the IPass system, but only we found about only less than half of them eventually got referred on.
Okay, so about 2/3 of them are managed through IPass.
Yeah.
Okay.
Yeah.
That's brilliant. So just quickly, if there are any more questions, please do type them in now, because otherwise we will finish the webinar. Okay, that's great. So thank you all very much for joining us and for asking your questions. Thank you particularly to Dr. Anthony Chan and Dr. Rupert Woolley for presenting this and for taking the time to do that. And thank you to everybody for bearing with the technical hitches, but hopefully you found this useful. And as I said, you will get follow-up email with links to all of the resources that have been mentioned in it. So thank you all very much. And in case you're interested, our next webinar is actually on the 30th, so next Friday, and is on supporting physical activity for musculoskeletal patients. So please do sign up for that if that would interest you. Thank you very much.